Hi, welcome to the platform of eGurukul and Dr Bhatia मेडिकल कोचिंग इंस्टीट्यूट। मैं हूँ डॉक्टर रम्या, आपके ऑब्गाइन गुरु। इस वीडियो में आपके एग्जाम्स बहुत नज़दीक आए हुए हैं, तो what I have planned in this video is I have kept all the placental images at one place so that it's a short video where you can quickly revise all the images of placenta at one place. So I'm trying to do some series of videos on the images so that it will be a quick recap for you all, and you will be able to revise it with these videos. The main purpose is that this videos will help you to revise those topics. So many students get confused between the placental images. So in this video, I have specifically done all the placental images at one place, guys. So myself, I am Dr. Ramya. So let us see the images of the placenta. So first, let me speak about the normal placenta. So normal placenta is discoid. The shape of it is discoid. It is hemocoroidal because it has half bled from the mother and half bled from the father. It is deciduate because it sheds off post-delivery, right? And it has two components. Fetal component is called as chorion frondosum, whereas maternal component is called as decidia basalis. It has two components. Fetal component is called as chorion frondosum and maternal component is called as decidia basalis. And it has two surfaces, maternal surface and the fetal surface. So if you observe, this is the fetal surface. So fetal surface has inner amnion and outer chorion. And this inner amnion is a smooth, glistening layer. So that is why the fetal surface is smooth and glistening, because it is covered by the amnion. So it is smooth and glistening because it is covered by amnion. And in the middle of the placenta, you have the umbilical cord insertion. And in the middle of the placenta, you have the umbilical cord insertion. Whereas maternal surface is rough, it is shaggy, it is divided into multiple lobes, and each lobe is called as cotyledon. So fetal surface is smooth, glistening, and in the center, because it is covered by amnion, and in the center you have the umbilical cord. But maternal surface is rough, shaggy, divided into multiple lobes. Called cotyledons. Okay. So let us see the first, and you almost have 15 to 20 cotyledons, and these cotyledons are the functioning units of the placenta. So coming to the first image. So first abnormality what I have is extracurrial placentation. So in extracurrial placentation, the chorionic plate, that is the fetal plate, the chorionic plate is smaller than the maternal plate, decidual plate. So here the chorionic plate is smaller than the decidual plate. See, decidual plate is complete from here to here, but chorionic plate is only from here to here. So we have two types here, circumvallate and circamarginate. So I call circumvallate as a pani puri placenta. जैसे पानी पूरी में you have a central depression and उसके अंदर दाल, batata or anything. So same way here also the placenta is like this. It has a central depression and you're seeing these all the veins. Okay, yeah, it's not pretty so convincing or good pani puri type picture, but yes, it's looking like a pani puri, and after this comparison you will not forget. Don't tell you'll stop eating pani puri after this. So circumvallate has a central depression and it has a double fold of amnion and chorion. It has a central depression and it has double fold of amnion and chorion, right? And in this fold you will have fibrin and dead clot deposition. So this is a circumvallate where chorionic plate is smaller than the decidual plate and it has a double fold of amnion and chorion. Okay, so the amnion and chorion has covered the placenta, leaving the center. Center will have a depression. Next, circummarginate. Circummarginate has only single fold of amnion and chorion. Basically, all these are just image-based questions for you all. Single fold of amnion and chorion. So it looks like a peripheral margin. This ring looks like a peripheral margin. What are the risks associated with this extracurrial presentation? So they can present to you with antepartum hemorrhage, preterm labor, and IUGR. They can present to you with an antepartum hemorrhage and preterm labor. So that's regarding the extracurrial presentation where the chorionic plate is smaller than the basal plate. Chorionic plate is smaller than the basal plate. So in the circumvallate you have double fold of amnion and chorion. In circummarginate you have single fold of amnion and chorion. I ask you to remember the circumvallate as a pani puri placenta with a central depression. Next, so I told you that in the maternal surface you have 15 to 20 cotyledons on the maternal. Normally in the placenta on maternal surface you have 15 to 20 cotyledons. When one cotyledon is separate from the entire placenta, but they are interconnected with each other, then you call it as subcentrate lobe. So when one cotyledon is separate from the entire placenta but they are interconnected, you call it as subcentrate lobe. So when one cotyledon is separate from the entire placenta but they are connected with each other, with membranes, then you call it as subcentrate lobe. So what are the risks associated with this subcentrate lobe? This cotyledon can be left inside, so it can present you with retained placenta. So because of this one cotyledon left inside, they can have secondary PPH. They can have infection, so that is puerperal sepsis. Uterus will not come back to its normal size at the same rate, so they'll have subinvolution. So they'll have retained placenta, secondary PPH, puerperal sepsis and subinvolution. So subcentrate lobe में one cotyledon is separate from the entire placenta. In that you have few more variants. So when one cotyledon is separate from the entire placenta and it is not interconnected, then you call it as placenta spuria. So here they will be interconnected with the vessels, and subcentrate mein they will be interconnected with the vessels. But placenta spuria mein there is no interconnection. Placenta spuria mein they are not interconnected. Next, another variety is in the previous two placentas which I told, it is only one cotyledon which is separate. But when you have the entire placenta divided into two equal halves, and connected by membranes and vessels, then you call it as placenta bilobata. So you should have the interconnections also. Okay. So what are the three varieties of placenta which I spoke just now? I repeat them once again. So subcentrate mein one lobe is separate from the entire placenta and they are interconnected by membranes and vessels. Spuria mein one cotyledon is separate from the entire placenta and they are not interconnected. So this is subcentrate. Interconnected is subcentrate. Sporia mein they are not connected. Next, you have two equal halves of the placenta connected with each other. That is called as bilobata. Placenta bilobata. So we have seen three varieties here. Subcentrate mein one cotyledon is separate from the entire placenta, but they are interconnected. Sporia mein one cotyledon is separate from the entire placenta and they are not connected. Bilobata mein one placenta is connected to the other, one entire lobe is connected with the other lobe and they are interconnected. Next variety is Velamentous placenta. So when the placenta, instead of getting connected to the fetal surface of the placenta, when the umbilical cord, instead of getting connected to the fetal surface of the placenta, if the umbilical cord gets connected to the membranes, then you call it as Velamentous placenta. So if the umbilical cord gets connected to the membranes, you call it as Velamentous placenta. So this again has high risk of fetal hemorrhage. So these vessels are unsupported. So any trauma can result in fetal hemorrhage. So the qualitative test to differentiate feto-maternal hemorrhage is qualitative test to differentiate the feto-maternal hemorrhage is apt test. Or it's also called as Singer's alkaline denaturation test. Singer's alkaline denaturation test. Okay. Next, see the previous one mein the cord is attached to the membranes. You also have one more variety called placenta furcate. So here, just before reaching the placenta, the blood vessels are getting separated. So just before entering into the fetal surface of the placenta, the blood vessels are getting separated. Then you call it as placenta furcate. Whereas Velamentous placenta mein, they are getting separated long before. And they are attaching to the membranes and all vessels are getting separated and then going into the placenta. तो यहाँ पे पहले ही separate हुए, बहुत पहले separate हुए, just before enter करने से पहले ही separate होंगे तो उसे placenta furcate कहते हैं. So I hope you understood the difference between furcate and velamentous. So velamentous में cord is attached to membranes. यहाँ पे furcate में the blood vessels are getting separated just before the insertion. Next है, so this is seen with, this is called VASA Previa. VASA Previa. So when fetal vessels with membranes are present below the presenting part and above the internal os, you call it as VASA Previa. I repeat, when fetal vessels with membranes are present below the presenting part and above the internal os, you call it as VASA Previa. So here again you have high risk of fetal hemorrhage. Here you again have the high risk of fetal hemorrhage. So what all kind of presentation can present to you with VASA Previa? Velamentous placenta, so Velamentous placenta, Subcentrated placenta, and bilobata, placenta bilobata. So in all these, the fetal membranes with vessels are present just above the internal os. So in all these conditions, that is Velamentous placenta, placenta bilobata and Subcentrated lobe. So in all these, the fetal vessels with membranes are present above the internal os. Fetal vessels with membranes are present above the internal os. Okay. So that is regarding the VASA Previa. Next, coming to the cord. See, VASA Previa, see, I am trying to show you all the images, two images which can be confusing. So, you saw the VASA Previa mein mainly it is the membrane and vessels. When you have umbilical cord above the internal os, that becomes cord presentation. So, you have three types of, regarding three different types in the cord. So, when you have presenting part along with the umbilical cord above the internal os, then you call it as occult prolapse. Matlab it is in the process of getting prolapsed. Prolapse means coming outside. When umbilical cord, when umbilical cord is present below the presenting part, then you call it as cord presentation. Cord presentation. When umbilical cord is present below the presenting part, you will call it as cord presentation. When fetal vessels with membranes are present above the internal os, you will call it as VASA Previa. Okay. Next, when umbilical cord comes out, then you call it as overt prolapse. Occult means it is at the verge of getting prolapsed, but it is not yet prolapsed. Membranes are intact. When umbilical cord comes out, you call it as overt prolapse. Okay. I have done one video on the channel of DBMCI where I have discussed about the cord presentation in detail. So do check it, guys. It is definitely beneficial because you got regarding the cord prolapse in your exam. So do check that video. It is in total how do we manage according to the guidelines, what are the risk factors, everything. So just type cord presentation Dr. Ramyashree. I think it will come in the platform of DBMCI. We have done that video. So I repeat, occult prolapse mein along with the fetal head, the umbilical cord is present. Cord presentation mein below the presenting part, you have the umbilical cord on the internal os, so it is called cord presentation. When cord comes out, you call it as overt prolapse. Next, we have morbidly adherent placenta. We have morbidly adherent placenta. Normally, placenta gets attached only to endometrium. So what are the layers which prevents the placenta to go beyond the endometrium is Nitabux fibrinoid layer. So whenever there is absence of Nitabux fibrinoid layer, whenever there is absence of Nitabux fibrinoid layer, whenever there is absence of Nitabux fibrinoid layer, it will result in the placenta going beyond the endometrium. And here we have three varieties, accreta, increta and percreta. Accreta is adherent to the myometrium. Increta is invades the myometrium. Percreta is penetrates the myometrium to reach the perimetrium. To reach perimetrium. So A for accreta, A for adherent, just adherent. I for increta, invades, I for invades. Percreta, P for percreta, P penetrates and goes to perimetrium. That's the outermost layer. So again, regarding, see, everything here, I just showed you the image for the quick recap, but I didn't tell about the placentas. So if you want to watch the placenta in detail, you can visit the eGurukul platform and you have all my videos in detail. And there's a good news that we have also done this time all the videos in English. So anybody more comfortable in English can watch the English videos where you'll have in detail about the placenta. Right. So now a quick recap for the exam going. Now accreta is adherent to the myometrium. Increta invades the myometrium. Percreta penetrates the myometrium to reach the perimetrium. So these are all the different images which we have about the placenta. So one quick recap. Extracurrial presentation, you have circumvallate, panipuri, central depression. Circamarginate, peripheral margin, single fold of amnion and chorion. Subcentrated lobe, one cotyledon separate from the entire placenta but connected. Sporia, not connected. One cotyledon separate from the entire placenta, not connected. Placenta bilobata, both lobes are two equal lobes have divided and they are interconnected. Velamentous cord is attached to membranes. Furcate cord gets when vessels get separated just before insertion. VASA Previa, vessel with membranes are lying over the internal os. Acal prolapse and overt prolapse are a type of cord prolapse. When cord is present over the presenting part over the internal os, you call it as cord presentation. Morbidly adherent placenta is due to absence of the Nitabux fibrinoid layer, where the placenta is going beyond the endometrium into myometrium. And you also have one more battledore placenta. When cord is attached to the margin of the placenta instead of being attached to the center of the placenta, when cord is attached to the margin of the placenta, you call it as battledore placenta. Okay. So that finishes regarding the placenta. A quick recap about the placenta, right? So see you in the next video. Please do mention what are the other videos you want for a quick revision before your exam. I am there for you to do those videos. Thank you.